Okay, everybody, welcome back. So we just finished talking about heart attack. We talked about arteriosclerosis, and we're discussing about the pathophysiology of the heart. Okay. What are some of the factors that places a person at a higher risk for an acute myocardial infarction? Okay. Cigarette smoking, vaping can put you at a high chance of having a heart attack. If you have high blood pressure for an extended period of time, you have high cholesterol, so you need to eat healthy, work out, don't get overweight, don't become a bariatric patient. Some of the factors that you cannot control is your age, family history. If you have a family history of coronary artery disease, race, ethnicity, and if you're male or female. Okay. Also, some of the other factors that can play a role in somebody having an NMI is stress. If you have a job that's like really, really stressful and you're stressed all the time, that can contribute to you having a heart attack. A sense of alcohol consumption, okay, and also poor diet. Okay, poor diet, you don't eat enough or you eat way too much and you become overweight. And when you become overweight, your heart and your lungs and all the systems and organs in your body have to work harder and faster to take care of you the way they're designed to. Okay? So, acute coronary syndrome. Acute coronary syndrome, call EMS because they have chest pain. Acute coronary syndrome is also called ACS, is a term used to describe a group of symptoms caused by myocardial ischemia. And remember, ischemia means tissue death. Myocardia or myocardium or myocardial refers to the heart muscle. As discussed earlier, myocardial ischemia is a decrease in blood flow to the heart, which leads to chest pain through reduced oxygen and nutrients to the tissues of the heart. This can be a temporary situation known as angina pectoris, or more serious condition, or can turn into a more serious condition as an AMI, acute myocardial infarction, which is a heart attack. Okay? So let's talk about angina pectoris. Angina pectoris, or angina, occurs when the heart's need for oxygen exceeds its supply, usually during periods of physical or emotional stress when the heart is working extremely hard. Okay? So angina is basically when the heart's needs for oxygen exceeds its supply. You start to have a panic attack and you start breathing really, really fast, but you're breathing too fast to supply your heart with sufficient oxygen. And I know that sounds really weird, but there are times when a person will be in cardiac arrest because the heart's going too slow or it's going too fast. There are times where you're going to have chest pain because you're breathing too slow or you're breathing too fast. When you breathe normally, you take a nice, normal, deep breath. When you breathe too slow, that's not enough oxygen. You're not breathing enough. And sometimes when you're breathing too fast, instead of filling the lungs up from there to here, you're filling them up like this. And your heart's going, whoa, what the heck's going on? You're breathing, but you're breathing so fast, you're still not getting enough oxygen into your bloodstream to supply the body with enough oxygen. So your heart's going to go, okay, I'm not getting enough oxygen. I'm going to give you some pain now. And that's called angina. Okay? Those symptoms normally resolve themselves over time. Once you start to relax, sit back, relax, your panic attack goes away, then the pain disappears as well. Okay? We talked about acute myocardial infarction. It's when blood flow is severely reduced or eliminated from your heart altogether. Okay? When you're dealing with a heart attack, okay, there's something we call the chain of survival. The chain of survival are 5 links, 5 chains from a fence that are connected, that are very, very important. These 5 things have to happen. If they happen, the patient has an incredibly good chance, incredibly high chance of surviving. When you do CPR on somebody, they have a less than If somebody has a if somebody's in cardiac arrest, and you're doing CPR on somebody, and you do CPR from them from the time you pick them up to the time all the way you get to the hospital, and you just do CPR and only CPR and nothing else, they've got less than a 20% chance of surviving. But if you introduce an AED into the situation, then the person has an over 80% chance of surviving. And I believe you guys have already started to review CPR. So there are 5 links in the chain of survival. First one is early recognition and activation of the 911 system. You recognize that somebody might be having a heart attack, so you call 911. The earlier, the faster you can recognize that somebody might be having a heart attack, and the faster you call 911 is the faster or the sooner you can get EMTs en route that have all that equipment and all those drugs that they can give this patient to start giving professional care. The next one is immediate high-quality CPR. Okay, we'll talk about that in the second half of the class. Third chain is rapid defibrillation. If you have an AED, get that AED on the patient as soon as possible and shock the patient. And we'll discuss why and how to do that later. Get basic or ALS, EMTs, basic cardiac paramedics on scene as early as possible so they can start the higher quality interventions. They can use mechanical or drug interventions to help get that heart going again. And then getting them to good post-arrest care, getting them to the hospitals where they can start getting the care from the doctors, the cardiologists, the surgeons, and the nurses who have a lot more equipment and they have a lot more bodies, a lot more people can work on that patient than what we can in the field. Okay? Better definitive care. Those are the 5 links, the 5 chains of survival. It is very important that you recognize and activate the 911 system, okay, and start CPR. The reason why it's so important that you want to start to get that blood circulating again is because about 30 minutes after blood flow is cut off, some heart muscle cells begin to die. After about 2 hours, as many as half of the cells in the area can be dead. And the area is the area where there's no blood flow because it's on the other side of the occlusion or the clot that blocked the blood flow. As many as half the cells in the area can be dead. In most cases, after 4 to 6 hours, more than 90% will be dead. In many cases, however, opening the coronary artery with the clot-busting medication, which is called a thrombolytic way of doing it, or an angioplasty, which is a mechanical way of going in and removing the clot, can prevent permanent damages to the heart muscle if done within the first few hours after the onset of symptoms. Therefore, immediate pre-hospital treatment and transportation to the emergency department are essential. They are very, very important. If a person is beginning to have a heart attack, it can start very mildly or it can come on really hard, really fast. Let's go with it starts very slowly. The person starts to complain of chest pain, difficulty breathing, they're lightheaded, crushing pain, someone sitting on their chest. The earlier you recognize that and call 911, the faster EMTs can get there. The faster EMTs get there, the faster they can start giving the patient some oxygen, start doing some other interventions that we can do, and the faster we can get them to the hospital. We get them to the hospital, the doctors and nurses evaluate them, they'll take them into the cath lab. Okay, they'll take them into the cath lab. They'll find the clot. Okay, they'll either give them a certain medicine that can only be used within a certain amount of hours of when the clot occurred, or they're going to go in mechanically and remove the clot. And it's really cool to see that done. I've seen them do it twice. I've been able to stand there in the cath lab next to the doctor, and they show me how they do it, and it's absolutely incredible how it's amazing. Okay, so it's very important that the faster that person gets to the hospital, the faster they get definitive care, the faster they can get in the cath lab, or the faster they can get the medicine, or they can use a mechanical way of getting that clot out of the heart to restore normal blood flow. Okay, and time is tissue. Okay, so what are the signs and symptoms of an acute myocardial infarction? Well, I just talked about them. Sudden onset of weakness, nausea, pain, pain in the chest. It could be sharp stabbing pain. It could be someone feels like someone's squeezing. They have these massive arms, hands, and they just wrap around their chest and they're squeezing the person's chest from the front, side, and back. It could feel like an elephant sitting on their chest. They can't catch their breath. They have shortness of breath. They have nausea, vomiting. Could even be that they have they're coughing up some pink frothy sputum. They're coughing up pink foamy stuff. Okay. Chest pain, jaw pain. The pain goes to their jaw. Pain goes down their left arm. Pain goes down to their abdomen or to their back. Okay. So the physical findings of acute myocardial infarction and cardiac compromise. The physical findings of an AMI vary depending on the extent and severity of the heart muscle damage. Okay. General appearance. What's the patient's general appearance? Are they unconscious? Are they sitting on the edge of a chair and they're just holding their chest or having a hard time breathing? How do they present? Okay, what's your general impression of the patient when you first see them? Pulse. Grab their pulse. Where are you going to take the pulse? Going to take the pulse at the radial pulse. And what I discussed with you guys last chapter 15, respiratory emergencies. When you're taking the pulse, what are you touching? You're touching the skin at the radial. Okay, so the skin, you're going to be taking a look at the skin color, temperature, condition. Is it cool, pale, clammy? Are you beginning to see signs of shock? Okay. Blood pressure. Is the blood pressure really, really low, or is it really, really high? Some heart attacks, the blood pressure is going low because the heart's giving up. Some blood pressures will be through the roof because it's too high. Respiration. What's the normal respiration rate for a patient? Are the respirations going slow, or are they way too fast? Mental status. Sometimes a person is clear-minded. Other times they seem like they're in and out of consciousness, or they seem confused. Okay, so you'll notice that. Let's see. I talked to you about dysrhythmia. A dysrhythmia is when it's an abnormal heartbeat. The normal heartbeat of a human is supposed to go beep, 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 just like that. If for some reason if it's not a regular beat, like a marching band, if it is not a regular beat, it is a dysrhythmia. Too fast, too slow, skipping a beat, beating 2 times where there should only be 1 beat. There's lots of different types of dysrhythmias out there. One of them is called tachycardia. Tachy means fast. Okay, tachycardia. Cardia, heart, cardio. Okay? The heart's going too fast. Someone is considered tachycardic, or they're considered tachy when their heart rate is over 100 beats per minute. Now, if it's going too fast, that's called tachy. What's the opposite if it's going too slow? Brady. Tachy and Brady. Tachy is fast, Brady is slow. Your heart rate is considered bradycardia, or Brady, if it's 60 beats a minute or less. Okay? Now, there are 2 heart rhythms that are out there that are not sufficient to sustain life. Let's say, I don't know for a fact, but let's just say there's 30 different types of heart rhythms out there. All different types. Fast, slow, jumping all over the place. Doctors can control them with internal pacemakers. They can control your irregular heartbeat, which is an arrhythmia, with medications. Okay? But out of those 30, there's only 2 of them that cannot support life. That's VTach and VFib. VTach is ventricular tachycardia, and VFib is ventricular fibrillation. Now, if you notice, I'm saying V, ventricular, VTach, and VFib. Remember the heart? The 2 on the top are the atria, the 2 on the bottom are the ventricles. Okay? Ventricular tachycardia, ventricular fibrillation. That means that the ventricles, the bottom part of the heart, is where the problem is. Ventricular tachycardia, or VTach, is when the heart is going way too fast. And it's usually at a rate between 150 and 200 beats a minute. Okay? You're tachy when you're over 100. Your ventricular tachy, your V-tachy, is when your heart rate's when it's over 150. Okay? Or VFib. VFib is the ventricles not beating the way they're supposed to. It's like going all over the place. Okay, best way I can describe that is VTAC is when your ventricles are going too fast. Okay, they're going so fast that it's not allowing the heart to fill up with blood before it squeezes again. So the heart's going like this, but the bottom's going like this. The heart's top like this, and the bottom's going like this. This is filling, fill, squeeze, fill, squeeze, fill, squeeze, fill, empty, fill, empty. But the bottom is going like this. It's going so fast, it doesn't have enough time to fill up with blood, so it's really not going to be moving any blood. Okay? VFib is when that electrical pattern I talked to you about, when the when the heart makes its own electricity, automaticity, and it starts at the SA node, and it jumps over to the right side of the heart, and the electricity is supposed to come down the front, the back, and the sides, and inside the heart nice and evenly, making the atria squeeze at the same time. Then right after that, the two bottom ventricles squeeze. The electricity is in a very controlled, smooth flow. It's a very smooth pattern. But with VFib, the electricity, it starts up here and it goes all over the place. It's like a lightning storm. It's not a controlled environment. So VFib is take a piece of gel and put it on a plate and then just jiggle it. And the gel goes all over the place. That's exactly what the heart's doing. It's just jiggling. It's not pumping in an organized manner. And in that organized manner, it's directing the flow of blood in and out of the heart. It's just going all over the place. So it's really not even pumping blood. So VTAC and VFib. And those are the two times when you use an AED, and we'll discuss that in your CPR course. Okay? So what you need to do is when someone's in VFib, VTAC, you want to get ALS on scene, medics and cardiacs, and give them medicine that'll slow the heart down. Okay? VFib is when you have to defibrillate the patient. Well, VTAC too. Okay? But you have to defibrillate the patient. Defibrillating the patient is when you shock the heart with an AED. An AED is an automated external defibrillator. Okay, it's going to shoot that patient with a lot of electricity, a lot of volts of electricity, around 1,890 volts of electricity is the average AED. Because in the medical field, we measure electricity with something that's called joules. A joule is equal to about 5.25 volts of electricity. The average AED, the original versions have about 360 joules of electricity. So you take 360 joules, multiply that by 5.25 volts, you're looking at about 1,890 volts of electricity. Now the average outlet is only 110 volts compared to the AED is 1,890 volts. That's a lot of electricity to shock the heart. You shock the heart to the point where the heart stops. And then it starts beating again, and it comes back in a normal cardiac rhythm. You ever seen a movie where someone's getting out of control, and they're, it's a crazy situation, and they're going nuts, and they just become completely hysterical, and somebody walks in, they smack them in the face, and they say, "Get a hold of yourself." And somebody smacks them, and they get hold of themselves again. They're like, okay, they come back to reality. That's what the AED does with the heart. It shocks it, it defibrillates it with so much electricity. It smacks that heart. And the heart is very dumb. The heart only knows to do one thing. The heart just knows to pump. It doesn't know what day of the week it is. It doesn't know whether it's hot or cold. It just knows it's supposed to pump. So if you smack with electricity, it stops the heart, and the heart's like, whoa, what just happened? What's going on? What am I doing? I'm supposed to be pumping. Okay. Pump, 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 pump. Okay. The AED shocks the heart, and it shocks the heart by stopping the heart. That's the AED's ultimate job. The AED's ultimate job, test question, is to stop the heart. The AED does not reset the heart. The heart resets itself. The AED shocks it with so much electricity, it makes the heart stop. Gives it a couple seconds to think about what it was doing, what it's supposed to be doing, and in the hopes that it'll come back in a nice, normal cardiac rhythm. And while you're waiting for the heart to do that, it's going to be the longest 1, 2, 3, 5 seconds of your life. Because not that you killed somebody, but you just stopped their heart when you shot it with an AED. Okay? So, if for some reason, and you've seen it in movies, someone dies and they're doing CPR and they shock them, and they say, everybody clear, clear. They shock them, the body jolts up like that. The body, in reality, the body only jolts a little bit. Okay? But when you have a flat line, normally, See, the heart goes up and down, up and down, up and down. Squeezes, relaxes, squeezes, relaxes, squeezes, relaxes. Okay? But when they have a flat line, that's called asystole. That's when the heart's dead. And you cannot shock an asystole heart. You can only shock a heart when their heart is neither in VTach or VFib. That's it. And the AED determines that. You don't determine that because you don't know how, but the AED can, because it measures the electrical pattern within the heart. When you put the pads in the upper right chest and the lower left side, it measures the electricity, and it can detect whether it's in VTach or VFib. And if it does, then it tells you to shock. If it's not in VTach or VFib, the AED will not shock. Okay? So, if you have not learned, you will be learning about shock. Shock is technically another word for poor perfusion. Remember, perfusion is the adequate supply of oxygen, mineral, vitamins, and nutrients to the organs and tissues of the body, and the removal of waste. If for some reason that delivery of oxygen, sufficient amounts of oxygen to the body through the bloodstream, you got to get the oxygen into the blood first. If for some reason there's insufficient oxygen delivery, which means there's probably insufficient blood delivery as well, then your body starts to go into shock. And your shock is basically the body's way of saying, well, something's wrong, we might die, I don't want to die. Okay, and it starts to take actions to save itself. So one of the types of shock is called cardiogenic shock. Cardio, the heart. Myocardium, the heart. Okay? Cardiovascular emergencies. Cardiovascular means the heart. So cardiogenic shock is a fancy way of saying the heart's not working correctly, and for some reason there's bad perfusion. There's poor perfusion. There's inadequate perfusion. There's inadequate oxygen and blood supply to the heart, to the body's organs and tissues. Cardiogenic, the heart, is because the heart's not working right. So when the heart is not working correctly, your body will go into cardiogenic shock. Okay? Cardiogenic shock is because the heart's not working correctly. And there's a lot of reasons that the heart could not be working correctly. It could be going through cardiac arrest. They could be having a heart attack. There could be previous injuries. People can actually have ischemia to their heart. They can actually have minor heart attacks, and they don't even know it. A little discomfort, but it's such a minor heart attack that it's not the full-blown, oh my God, I got to go to the hospital. Okay? It could be that there's a little bit of damage done to some of the myocardial tissue, or some damage, some minor tissue death that is causing the heart not to be as effective as it should. Heart doesn't work as effective as it should. Its cardiac output, its cardiac stroke volume is not sufficient, and it's not pumping the proper amounts of blood through the heart, through the lungs, to the body. Okay? So that leads us into something that's called CHF, congestive heart failure. Okay? So as you remember, I said that when the blood comes back to the heart by the vena cava to the upper right atrium, down to the bottom right ventricle, through the pulmonary vein, pulmonary referring to the lungs, pulmonary vein goes out to the lungs, goes through the alveoli. We all know about the perfusion and diffusion process that takes place down there. Drops off all the CO, picks up a crap load of oxygen, comes back to the heart via the pulmonary artery, comes back to the heart in the upper left atrium, goes down to the bottom left ventricle, and gets squeezed out to the rest of the body. Okay? CHF occurs because the lungs, not going to say it, the lungs become congested with fluid once the left side of the heart fails to pump the blood effectively. So, remember what I said? The strongest part of the heart is the bottom left ventricle. That's the strongest, thickest part. The walls of the heart are the thickest and the strongest on the bottom left ventricle, because blood comes up to the upper right, bottom right, goes out to the lungs, comes back, goes down, comes to the upper left, bottom left, and from the bottom left it gets squeezed, and it goes through the aorta through the rest of the body. Okay, it goes up through the carotid artery supplying the brain, the face, the subclavian arteries to the upper extremities, to the aorta going down, goes down to the iliac, goes down to the femoral artery, so then that supplies the lower extremities, and then the blood comes all the way back. If for some reason the left ventricle, the bottom left part of the heart, is injured because of tissue death, or some maybe blunt force trauma to the chest from an accident, MVA or something like that, if the left side of the heart is not working as effectively as it should, it doesn't have the amount of pressure. It doesn't have that good, proper blood pressure we're supposed to have. So if it doesn't have the proper blood pressure, then you have fluid back up. When the blood leaves the heart, goes into the lungs, it's supposed to have enough pressure to come all the way back out of the lungs and back in the left part of the heart, goes to the rest of the body. If for some reason that pressure is not where it should be, you're going to get a backup of liquid in the lungs. Okay? And that's what CHF is. So that's going to result in difficulty breathing. That's going to result in the bottom part of the lungs having fluid in them, just like pneumonia. Starts in the bottom, works your way up. Some of those alveoli in the bottom of the lungs are submerged in liquid, submerged in blood and water, and they can't perfuse and diffuse oxygen. So it's going to give you difficulty breathing. So that's known as congestive heart failure, otherwise it's called CHF. Okay? So when you have a left-sided injury to the heart, that results in CHF. Okay, congestive heart failure. Okay, if the right side of the heart is damaged, fluid often will collect in the body, usually the parts of the body closest to the ground, and those are your feet and your legs. So that means that you're going to have fluid buildup. When the left side of the heart doesn't work as effectively and the pressure is not where it needs to be, you have fluid buildup in the lungs. Okay, resulting in pulmonary edema, difficulty breathing, and CHF, congestive heart failure. If the right side of the heart is not working as well, then you're going to have fluid buildup in the lower extremities of the body that's closest to the ground, as I said, which are your legs, and your legs are going to start getting puffy. And it looks like there's fluid buildup. You're going to have really thick, puffy-looking ankles, thick, puffy-looking feet, toes. That's called edema, because that fluid can't make it from there all the way back up to the heart and get circulated again. Okay? Some of the other problems we talked about the heart was hypertension. Hypertension is high blood pressure. If you have hypertension for an extended period of time, number of years, that can cause the heart to get very tired. That can cause damage to the heart. And that can cause and create future problems with the heart as well. One of the most common signs of a sudden severe headache. So we discussed some of the signs and symptoms of a heart attack. We also have hypersensitive, high blood pressure situations where someone thinks they're having a heart attack and they have a lot of very similar signs and symptoms. And that's called hypersensitivity emergency. Hypersensitivity emergency usually occurs when the systolic blood pressure, the upper number, is higher than 180. Okay? One of the most common signs is a sudden severe headache. People describe it as the worst headache that they've ever had. It'll also show as they're going to have a really, really strong pulse. You go to take their pulse and it feels like their arteries are going to pop out of their arm, pop out of their wrist because it's so strong. Whereas most of the time you have a hard time finding it. Ringing in the ears, they're going to have nausea and vomiting. They're going to be dizzy, and they're going to have warm skin or they have moist skin. They might have a nosebleed, and they're going to have altered mental status. Okay? So basically, someone with high blood pressure for an extended period of time is going to go so high. Some people can tolerate better than others, but on average, most people, when their blood pressure becomes over 180, they'll start to feel it. Some people, with their blood pressure can be 200 over 110, and they don't feel it. But those people that do feel it, they're going to have those signs and symptoms. They're going to have a massive headache. It's going to come out of nowhere. They're going to ring in the ears. They might have blurred vision. They might have a hard time talking because they think that they're having a migraine. Okay? But it's not a migraine. It's increased pressure in the skull, in the brain, because the blood pressure is so high. Nausea, vomiting. They can't think straight. They just want everything to be quiet so they just concentrate on it. And you can actually hear the blood. You can actually hear it going through your ears. You can actually hear it. It's really weird. Okay. There's another hypertensive emergency. It is called an aortic aneurysm or an ascending aortic or dissecting. An aortic aneurysm or a dissecting aneurysm. An aortic aneurysm, first of all, what is an aneurysm? An aneurysm is when you have a blood vessel and a side of the the side or one section of the blood vessel starts to become very thin, becomes weak, and it starts to bulge out. A tire in the car, there's one section of the tire and it starts to bulge out. Or a garden hose. And a garden hose is nice and long, is long tube, but one section has this little bulge on it. That's an aneurysm on the garden hose or an aneurysm on the tire. One section of the wall of the tire or the garden hose has become very weak and it's beginning to expand. It's going to begin and it breaks. Same thing can happen with the aorta. The aorta is the artery, it's the largest artery in the body, and it starts in the heart. When the bottom left ventricle squeezes, it's squeezed with a ton of pressure, and that blood's got to come up. Some of it goes to your brain, some of it goes to the upper extremities, and then it takes a quick turn. It's like a, what do you call those, roller coaster. And then it loops around, and now it's going to start heading down. And where that turn is, where that curve is, the aortic arch, they call it, all that pressure is like, okay, it hits it, then it comes around and goes down the back. But that's constant. So sometimes that aorta, because of high blood pressure through many years and poor health, the walls of the aorta, either up here or down in the lower part of the body, it'll become weak and it'll start to bulge out. And that's called an aortic aneurysm. Okay? Hopefully doctors can find it before it pops, because if an aortic aneurysm pops, you're dead within about a minute. Short of you being on the operating table and the aneurysm popping right then and there, you still run a 50-50 chance of dying. Because if that pops, think of it, every single time your heart pumps and you got a hole in your aorta, half the blood goes out and the other half goes to the rest of your body. But you also lose pressure. You're going to bleed to death. And you're going to bleed to death within 30, 45 seconds, 60 seconds at the most. Okay? Now they have a thing that's called the dissecting aneurysm. And that is just like your skin. You have 3 layers of skin, right? Remember what they are? Your aorta has layers of tissue. Instead of just the one section of the wall just becoming weak and it gets bigger and then it pops. And you got an opening right here. The tissues, the layers of tissue within your aorta, blood will start getting in between the tissues. And it's sort of like layers of a cake. The icing is between the layers of the cake. Well, in this case, the blood is forcing itself in between the layers of the tissue. And then it pops. That's a dissecting. It's dissecting, it's cutting into your aorta. Eventually it'll pop. Okay? That's about it for the descriptions of things like that. We're going to start talking about patient assessment. So I'm going to stop here, give you guys a break, grab a pint of tea, grab something to drink, take something to wake you up, and I will be back shortly. Take care. Bye.